But let's talk about the elephant in the room now. The story about Neratinib is not complete unless we tackle the problem of diarrhea. Diarrhea is the big problem, and it's the main challenge. Dr. Kang, I'm going to start with you. What is your way to approach the diarrhea and mitigate the chances of having diarrhea?
So this is certainly where I apply the control trial that really, helped guide and develop, several treatment or treatment strategies that optimize patient tolerability and minimize diarrhea on Neratinib. What really stood out in the control trial were the two arms that used a dose escalation strategy. So there was a sort of 2-week dose escalation strategy as well as a 4-week dose escalation strategy. One, you started at 3 pills a day and then slowly escalated up to full dose 6 pills a day. And the other, you started at 4 pills a day and escalated up to 6 pills. And I think whichever one you choose or where I land on in clinic sort of is a discussion with patients and sort of how fast they want to escalate. But key here is that you start low and you ramp up to sort of maximize tolerability as well as adherence. It really minimized, diarrhea and especially grade 3 diarrhea in the first couple of months. And then what we see on Neratinib is that generally that's when you hit sort of severe diarrhea. And then after month 2, you're really not going to see sort of flares or surges in diarrhea. And so once sort of accessing good control and good tolerability in the first 2 months are key. And I use the dose escalation strategy.
Fantastic. I have a follow-up question, if you don't mind. Do we have to get to 6 pills to get the full benefit of that drug?
We do know that from the control trial that, patients who just were on drug for, 12 months, that I think that's the sort of ideal.
Yeah, I can tell you in my practice, I rarely have 6. I have one case, that patient, I took her to 6 pills that had 0 diarrhea on every single dose escalation. So then I was like, okay, we should go to 6. But I truly feel the sweet spot maybe is 5 pills. 5 pills really keep you away from trouble. I have some patients at 4 pills. I think 4 and 5 are still pretty effective dosage. We don't need, I think the message should be there to the treating physician that 6, maybe it's too much. And
right, I don't feel the need to.
Yeah, we shouldn't. Yes, we shouldn't. If patients are having already enough, like they got their sweet spot at 5 pills, you have a statu quo, take it. Don't push your luck.
Get to 12 months, right?
Yes, get to 12. I like that. Yeah. Get to 12 months. Don't try to push. Dr. Birhiray, can we talk a little bit about what other medications we have to help manage the diarrhea? Mainly, I want to focus on, there is a lot of drugs that we can use. There is the loperamide, there is Lomotil, there is Colestipol, there is other drug like budesonide and stuff that you can add. What is your favorite approach when it comes to the management?
My favorite approach is not to add anything, frankly, but loperamide is probably the one that I use the most when necessary. And it's amazing when you ask patients, are you taking your loperamide? Oh, I forgot. You get a lot of that. So re-emphasizing to patients to take their medication is important. My nurse practitioners, when they're seeing my patients, they like to use Lomotil or diphenoxylate atropine. They seem to think that it's more effective. I don't necessarily buy into that, but that's what they will do. And I don't like doing that because it's a controlled substance and I have to write the controlled substance prescription, which I hate to do. So my preference is the dose escalation and loperamide. The Colestipol and budesonide, yes, they are there, but I think that's just, I try to really avoid using them, but if necessary, I would.
Yeah, my problem with loperamide is that I tried it before, so I'm very biased against it.
We all have biases.
It's such a bad medication. I mean, you're essentially replacing diarrhea with a sledgehammer. It's truly a sledgehammer. Like you feel very constipated, very bloated, severe crampy pain. What happened with our patient is that, and this is my theory, and I did prove it because I asked a few patients about it, is that they try it, when they start Neratinib, if they have a loose bowel or like a diarrhea that's not that bad, they try the loperamide and be like, oh my God, this is much worse than the diarrhea. And then they be like, okay, we're not going to use loperamide unless the diarrhea is bad. And then they're trying to play catch up. And playing catch up is not going to work, right? You need to be proactive with that drug. Lomotil, yes, is a controlled substance, but I found that it does not give the severe constipation that loperamide does. At least that's my clinical experience. And that's why I tend to do it. And yes, I don't like to give controlled substances, but thankfully I only have to do it for 1 month for those patients. And you're right, because like you said, Dr. Kang, is the diarrhea problem is the first month, right? You control it, it should be cruise control from there. So if we can control it, be proactive about it, that's the best way.